you a woman in medicine feeling overwhelmed and disconnected from the personal fulfillment that you desire? You're in the right place. Join Doctors Joanne and Aaron as they rewrite the rules for women in medicine. Let's begin.
Welcome back to another episode of Create Meaning in Medicine. Today, I am so excited that we have Dr. Aoife O'Sullivan here, and she is a menopause expert. And Joanne and I are going to be asking all of our questions about menopause today with Dr. O'Sullivan. And just to share a little more about her, she has over 30 years of training and experience specializing in the comprehensive care of midlife women, which I know I'm excited about. She is a dedicated advocate for women's health and a member of multiple societies focusing on menopause and women. She is the founder of Portland Menopause Doc. I love that name. And she has a thriving telemedicine practice and provides care to patients in Oregon, Washington, and Connecticut. And over the past few years, she has focused her practice on menopause care, finding immense joy in helping women through this transformative stage of life. Welcome.
Thank you so much for inviting me on. I'm delighted to be here.
Aoife, this is Joanne. So excited. I have been looking forward to this episode because I might or might not be going through menopause myself at this point. And I know that our listeners, many of them are women in medicine or, women in general. And most of us are mid-career, and there's so much information out there. It's so confusing. It's so overwhelming. And like I've heard you talk about before, there's an ingrained information from a couple of decades ago that has been challenging to change. So I'll start. Let's go straight to it. And I'll ask you, it's kind of like a big question, but I'll have you choose what's important. So tell us what we need to know about menopause and perimenopause, and why is this a passion for you?
Okay. So menopause is a massive hormonal transition in women's lives. And I feel anyone who has a child knows that they try to prepare their child for puberty. We buy books, we listen to podcasts, we get advice, and we teach our children, at a certain point, their period might start, they might start to grow hair. And I think we're pretty good at all that. Pregnancy also, we have so much information available and we pump women full of it once they're expecting a child. But then, women are 51% of the population in this country, and nobody knows about this third massive hormonal transition that women go through. And it boggles my mind how we have got to this point where probably, I'm sure at least 50% of doctors are women. And 51% of the population are women, and yet nobody knows about this. And it has such a massive effect on our lives because it affects almost every cell in our body.
And I want to just pipe in here because not only are women physicians dealing with this maybe in themselves or perimenopause, which can happen, many years before, they're also dealing it with their patients potentially, and depending on their specialty. And one of the things that I've been intrigued, especially by learning more from you, I've attended a workshop of yours before, other interviews with you, is just how, I want to say, skewed some of the information is and how limited it is. And oftentimes we have that mindset, well, I'm the doctor, I know what I'm talking about. I would love to hear if you'd share a little bit of your own story about just how limited that information was and how you had to do an extra deep dive in to become such an expert in menopause. Do you mind sharing some of that?
Not at all. I'd love to. I mean, I've been in medicine for a long time. I have never come across a situation like this. It is truly bizarre. So, medical school in Ireland is 6 years long. And then I did a family medicine residency there, which was 3 years, and then moved over to America, and they didn't accept any residencies done outside the US. So I did another 3-year residency over at the University of Maryland. And that's 12 really excellent years of medical training. And I remember as a resident in the residence clinic, approaching one of my mentors and saying, this woman is here for a refill on this patch. And I don't know what it is. And I don't know how to refill it. And what is this? And it was an estrogen patch. So this is after 12 years of medical training. I had absolutely no clue about menopause or how we treat it. And I think throughout my whole career, there has always been a feeling that I was missing something. Because at a certain point in time, women would start to come into the clinic. Women who I would have seen maybe once a year, for their annual checkup. And now they were here almost every month with tendon issues and headaches, mood problems, and energy problems, skin issues, hair issues. And I must say, I always felt I was missing something. And, often you go down the route of, I can't find a cause for your hand joint aches and pains and why you're so stiff in the morning. And I've done all the rheumatology lab work and I can't find anything positive. And that would end up being a rheumatology referral then. Or, the $1 million workup when a woman comes in with some palpitations and you check an EKG and you check an echo, everything is normal, blood work is normal. And then you have no choice but to refer that woman to cardiology, where she then gets the massive workup and never gets an answer. And, from experience, I know if I put that woman on an estrogen patch, within 48 hours, those palpitations are gone. So just it's this miraculous side of medicine that I went through most of my career not knowing anything about.
That's so interesting, because I just had a coaching call this morning and was talking to a primary care doc. And we talked about a patient interaction where she was so frustrated. And the bottom line is this patient is not getting answers. Or is fixated on something that maybe Western medicine doesn't have a great answer for. And that lack of answers can drive so many appointments and so many specialty visits. And yet you're saying, if we all had a better understanding, maybe as patients and physicians, maybe the answers would come much quicker and easier.
Exactly. For me now, I feel as though everything about the human body and medicine is contained within 2 volumes of text. And we have only been taught from volume 1. And there's a whole volume of text that we are completely missing from our training. It's not woo-woo. It's not, any kind of fictional color therapy. It's real, solid, evidence-based medicine that is lacking from our training right from day one of medicine. It's not in medical school, it's not in residency, and it's not in anyone's fellowship either. And every single woman and every single doctor needs this information. You just can't practice properly without it. I just find, since I learned about ovarian neuroendocrine hormones, my job is so much easier. Now, it doesn't boggle my mind anymore how this woman can have symptoms from every single system in her body. I look at her symptoms and I'm like, yes, I know what's going on. Let me help you. It's just so easy now compared to what my job used to be like.
I have a question. First of all, thank you for using the word massive hormonal transition. I felt that in my body, because it's reassuring for us to be like, you're not making this up. These are real changes that are affecting your whole body. So thank you for acknowledging that. And what comes to mind in hearing you, as a psychiatrist, I'll ask some in a minute, but here, what I hear, it's the patient saying, aren't hormones bad for you? What do you say? Like, what do you explain to someone when they're afraid of what can actually be helpful?
Yeah. So I think as doctors, everyone is afraid as well. And this is why it's really difficult to do menopause care in a normal 10 or 15-minute clinic visit. It's almost impossible, because if somebody comes in to me and they have high cholesterol, I'll sit down with them, I'll open up the computer, and we'll do that Framingham risk calculator together. We'll put in all their numbers, their blood pressure, their cholesterol, their age, their gender, everything. And the two of us will look at it and I'll say, look, your risk is 9% of having a heart attack or stroke over the next 10 years. Let's focus on diet and exercise and everything. But also, I really think a statin would keep you safe and prevent you from having a heart attack or a stroke. But I can't do that with hormones. I have to go back 20 years. I have to go back to the 1960s and explain how we found estrogen and what happened from that point onwards, because I need to give my patient that understanding and speak to them about the studies that we have on hormones so that they feel comfortable with me prescribing hormones. Because if you don't, your patient will come back for follow-up and they'll say, I went and I picked everything up from the pharmacy, but it's sitting in the cupboard. I was too scared to take it.
Right. Yeah, no, it's so important. And we've talked about that before. When we need, as physicians, we need to get our patients involved in the treatment plan, and then also ourselves when we show up as patients, to really understand the importance of trust and the rapport with the doctor, and to know that you know what you're doing as the physician in giving that information. And yes, unfortunately, most physicians don't have the luxury of time, and we end up in this 10-15 minute quick yearly appointments, and it's sad the way it is. And it's so neat to hear you and so many of us who are approaching medicine from a different standpoint of what does the patient really need, and again, as women, what do we need, and what are the questions to ask, how do we prepare better for those appointments, whether we're on the doctor's side or in the patient's side. So thank you for that work. That's impressive.
Thank you.
Well, and we've talked a little bit about this already, but why do you think it's so important for women physicians to have a better understanding about perimenopause and menopause?
So, number one, because if they live to the age of late 40s, 50s, they will go through menopause. And number two, because I'm sure at least 50% of their patients are female. And the other thing that happens throughout the menopause transition is that if you look at studies, women leave their jobs during the menopause transition. If you speak to divorce lawyers, women get divorced during the menopause transition. And also when you look at suicide rates, there is a spike between the ages of 45 and 55, and that is women going through the menopause transition. So again, massive hormonal changes affecting every single cell in your body. And as a female physician, you need to know about this so that you can stay in your job, stay in your relationships, and keep your mental health in good condition and your physical health in good condition. You know, we used to die in our 50s 100 years ago. So you'd have your birthday and a few hot flashes, and then you'd die from the influenza, you know. But now we're living, you know, between a third and a half of our lives after menopause. And our bodies don't work properly in general. You do find the odd woman who makes more estrogen after menopause than others through, not through ovarian function, but maybe from aromatization of testosterone peripherally, or production of estrone from fat cells. But in general, we after menopause don't have any hormones, and we do not function well like that.
That's just mind-blowing, those statistics you shared, not only on what negative repercussions spike for women going through changes, but then also how much of our lives we're now living in menopause. And think about that amount of time that was missing too in the medical research and in knowledge, and how slow we can be to change in medicine. Just shocking in some ways. And what I love, I wrote down the word awareness, because one of the goals with Joanne and I having this podcast is raising awareness about issues. And so then people can tap into their curiosity and say, I need to learn more about this. How am I going to function as a woman physician if I don't learn more about this? And so very intriguing information that you've shared with us today, which I'm so appreciative of. And one aspect that I have that might be different than other people is that when I dove into child abuse medicine and specialized in that for the last decade of my career, I was flabbergasted that training in child abuse medicine was one day in all of my medical career. And 4 years of medical school, 3 years of residency, I chose to add a month on with a child abuse specialist, which helped me then set up for the rest of my career. But I said, I didn't read the ACEs, Adverse Childhood Experiences research article. And it was written by a person who worked for my same organization. And yet it wasn't, when I worked for them, I didn't hear about this article. It wasn't until I started working in child abuse medicine. So similar circumstance where it's decades into my training and I'm like, wait, what? Every physician doesn't need to know about adverse consequences of childhood. And this is a totally different tangent, but that big shock of how could we even do medicine well if we don't understand the effects of trauma in childhood for ourselves or our patients, if we don't understand the effects of women hormones.
Yeah, and it is actually really tied in, Erin, because your ACE score or your history of childhood trauma really affects how you will experience menopause. Often women with a higher ACE score will start going in through that menopause transition earlier, and they'll have more severe symptoms and they'll last for longer.
Well, it's so interesting. And thank you for also bringing the information about the suicide spikes, right? And I'm biased as a psychiatrist. And just this week, I had a patient I have been seeing for a long time. She's in her early 50s. And I've seen her through life's transitions and some kind of stressors since she's had a little bit of anxiety and panic attacks. And otherwise, fairly stable from her mental, emotional standpoint. And then lately, she's been super tired. She's gained weight. Her mood is up and down. She's been more anxious, has had a few panic attacks, foggy. And she's, poor thing, desperate, and then saying, what's going on? Do I need more medications? And we've been very conservative with her medications. And she's been dieting. She's been keeping her sleep hygiene. She's working out a little bit. She's doing all the things. And I had that conversation of, I believe this is menopause that's creating, because she's there, like you were saying earlier, blaming herself, wondering, what am I doing wrong? What's going on? Am I breaking? And then I could feel her shoulders coming down and hearing me as a psychiatrist saying, I can help you. And yet I believe that there's a big contribution from your hormonal transition. And yes, go see your OB-GYN, and yes, be open to whatever they say in terms of hormonal treatment, because she had fear about that and she trusts me. So she wanted to hear my impression. I said, yes, please. Just, I'm not going to do it, but yes, please. Not me personally, like me as a psychiatrist. Like, I'm not going to play OB-GYN and treat her, but kind of reassured her to say, yes, please listen. So I wanted to hear from you in your experience as a non-psychiatrist, but I bet doing a lot of psychiatry anyway. One, what do you hear? Like, what are the patients showing up with? And how do you reassure them? How do you help them?
I'm just going to go back a little further to just one thing you said there, and then I'll go straight on to that. But I feel like throughout our medical education, there is this underlying, even unspoken training that happens that women are complainers, moaners, just tune them out. You can't make them happy. They're difficult. And I have to say that all comes from lack of knowledge, right? I can see that now. And what I have found in my practice is that women are so resilient. They are so resilient. The things women have been through by the time they get to me, and the abuse that they have sustained in the medical system, and the medical, it's such an awful word to use, but medical gaslighting that has occurred. And it's gaslighting that happens even kind of accidentally, like doctors don't know what they don't know, right? But from a patient's point of view, they're going to their doctor saying, I have XYZ symptoms. And the doctor is saying, no, you don't. I mean, a woman going into her doctor and saying, I haven't changed my eating habits. I haven't changed my exercise habits. I gained 10 pounds in the last 2 months. we all know as doctors, you're kind of thinking, yeah, you probably have changed your eating habits and you probably aren't exercising. But now I know, no, just believe your patient. She's telling you the truth. This genuinely happens. So I really think it takes a big mind shift as well for doctors we need to eradicate that kind of thinking in medicine, because that doesn't happen when you're dealing with men. A man comes in and tells you something, there's not a second where you think, I don't really believe that. You just take it as the truth. And then as to what's going on, so, during our reproductive years, between the age of when we start having our periods until we start to experience menopause, we get these lovely waves of hormones, during the first 2 weeks. So you start bleeding up to ovulation, you get this nice big wave of estrogen, and then the egg is released. If you don't get pregnant, that those supporting structures that were supporting the egg on the ovary get converted into a body called the luteal body, and that produces a big wave of progesterone. And so we have these lovely waves. And then as our egg supply from the ovary starts to drop in our 30s and 40s, we are not ovulating like we used to, and we're not producing those lovely waves of progesterone in the second half of our cycle. And so one of the things that progesterone does, one of the many things, is within the brain, it gets converted to a substance called allopregnanolone, which acts on our GABA receptors. And so as those levels of progesterone drop throughout perimenopause, the first thing women will come in and say is, I have either new or worsening anxiety. And it's often this really weird anxiety. It's like, I can't drive over bridges anymore, or I wake up in the middle of the night convinced someone's going to kidnap my children. And can't get to sleep. It's usually initial insomnia. The middle of the night insomnia is so connected to estrogen levels in general. So the first two things women notice are the anxiety and can't get to sleep. And so often, even if I just start them on a little progesterone at bedtime, completely takes care of that. And so if you leave a woman like that and she's now missing out on her sleep, and her progesterone levels are dropping, her estrogen levels are dropping, everything just starts to spiral, because once you lose your sleep, all bets are off after that.
And because I've heard you talk about this before, and there's some fear, again, related to research in the 60s and about what if there's negative consequences. But I heard you share kind of flipping that and saying, what's the harm in giving it a try? And you're saying within 48 hours, somebody may have some improvement. So share a little bit more about that maybe in your medical practice, and how that's different from your approach in years past before you became such an expert.
So again, it required a lot of training. So, once I started going through perimenopause myself, had no idea what was happening to me. And actually, I think my phone picked up on things I was saying and started sending me, filling my feed with menopause specialists. And so I was listening to these little videos, these little reels going, hang on a second, could this possibly be what's going on? And so one of the first things I did was I did a course by a primary care doc in England called Louise Newson. And she has a fascinating history. She's done lots of different things, but she herself was going through menopause as well and discovered all of this. And then it blew her mind. And she thought every single clinician needs to know this information. Every single woman needs to know this information. So she created an incredible course, and it was free at the beginning. And so I was able to sign up for that, and you can do it at your own pace. It's a teachable course. Then she put a price on it, very low price. It's like $8 a month or something like that until you do the course. And you can do it at your own time. And that was the beginning for me of learning about these neuroendocrine hormones that previously in my medical education have been reduced down to sex hormones, which doesn't really make them sound very important. Whereas they're actually neuroendocrine hormones. They affect every single cell in our body, especially our brains. And so what I normally see coming into me in the clinic is women with a lot of brain symptoms. So the hot flashes and night sweats are from your hypothalamus. So our hypothalamus, there are neurons up there, collections of neurons called candy neurons, KNDY, and they like to be bathed in estrogen. And when our levels are going up and down, which is what happens in perimenopause, they do not like that. And so even the tiniest change in our environmental temperature will make those neurons think they're in the Sahara Desert. And that's what causes those night flashes, night sweats and hot flashes. And, you know, there's a big study going on called the SWAN study. It's been going on for since the 90s, I think. All those women were in perimenopause. So they're all postmenopausal now. They're in their 60s and 70s, I think. Over 3,000 women, a nice selection from the whole population, you know, not just rich white women. And so they've been studying these women for years and years. And what you see is that women who have hot flashes or night sweats or both, there's a direct correlation between those and cardiovascular disease, so heart attacks and strokes. How this is not front page news is just beyond me. I do not understand it. You know, as soon as we find out there was a connection between erectile dysfunction and cardiovascular disease, you know, that if a man comes in complaining of erectile dysfunction, you're sitting there thinking, now I need to do a cardiac workup. He's thinking about his sex life and you're thinking this guy's in trouble. And yet a woman can go to her doctor and say she's having hot flashes and night sweats 25 times a day, can't get to sleep at night, and we don't know to worry about cardiovascular disease. So if you leave a woman with those vasomotor symptoms untreated for years, she's having changes happen all over her vascular system. So the other brain symptoms that I see a lot of are the mood changes, a lot of anxiety, irritability, and one thing so many women will say is rage. They just feel rage when they've never felt that before, and it's completely out of proportion to anything that's going on at the time. So there's a lot of guilt and shame connected to that as well, because often the rage is at a loved one, and they really don't enjoy feeling like that at all. It's awful. And then the, you know, memory problems, focus, concentration, and brain fog, and lots of word finding. And so I'll see a lot of women who have undiagnosed ADHD and they've been holding their life together, you know, with post-it notes and reminders on their phone and everything has a home. And then they hit perimenopause and it all falls apart.
That is so fascinating, because that was one of the areas I wanted to connect with you on, because many women, I think there's more women in medicine than I initially thought of, who have ADD, ADHD, focus issues, and that you hit a different stage of your life. So as a pediatrician, I sometimes saw when they went from elementary to junior high to high school, a big one, high school to college. So when they hit that next level of either difficulty or, as you're saying, now a lower level of functioning, then the whole basket dumps over and everything's a mess. And so, or maybe that's the first time they find that they have ADD or ADHD, when their hormones change. So I'm fascinated about that. Any other insight that you have from your area of expertise about maybe what people can look for and go, oh, maybe that's me?
With regards to ADHD?
Yeah, or other, because especially with ADD, ADHD, many people think, oh, that's a diagnosis of childhood or, you know, young people. And thankfully, I'm seeing lots more awareness about it. New diagnoses in your 30s, 40s, and 50s. And I wonder, again, just raising awareness, what are some clues that could this be you?
So, and also, you know, childhood trauma can look a lot like ADHD as well. As you grow up and age. So I think women will notice, you know, the word that is said repeatedly is the word overwhelm. So they just feel completely overwhelmed. So usually they are able to multitask. Their ADHD for a lot of women is kind of like their little superpower. Like, it allows them to race around and get everything done and think about 20 things at the same time and manage kids, partner, house, job, everything. And so I think, your hormones changing, really affecting your sleep. And then that has that knock-on effect of you not having the resilience, really, because you're so tired and your brain is not working because it doesn't have the hormones it needs. That then, previously you've been able to hold it together and now it just feels like you're drowning. I think that's what most women would describe it as.
And I heard you. Oh, I was just going to say, from my own personal experience. So I went through this differently. I was maybe in perimenopause. And then at 41, I had a preventive oophorectomy. So ovaries out to decrease my cancer risk. And so overnight, I had this transition into lack of, ovary production of any hormones. And what I noticed is I was still in general pediatrics and on call. And I thought, oh my God, my memory, like the word recall, I thought I was going crazy. And what I found is that if I got less than 4 hours of sleep because I'd been on call or I was up with my kids, I couldn't think straight. And I thought, oh my gosh, what's going on with my memory? Do I have, is dementia sitting in at age 41? And nobody told me before I got my ovaries out, you need to be aware of these possible symptoms. And, had a male OBGYN who did the surgery. But I think like it took me figuring out what the cause was. And I had heard about the mood things. I had somebody, say, oh, I totally went crazy when we went into menopause, or asked my husband, you think you're going to handle me on menopause? And I thought it was going to be the mood issues. And for me, the memory was such a big hit and nobody warned me about it.
So if there's anyone listening who has an upcoming risk reduction oophorectomy, the standard of care is really to put that woman on hormones immediately until the age of natural menopause, which in America is about 51, 52 years of age. From all the research that we have, a lot of women are having risk reduction surgery because they have Lynch syndrome or they have BRCA1 or BRCA2 or other genetic mutations. And what all the studies that we have show that doing a risk reduction oophorectomy and then putting a woman on hormone replacement treatment does not increase her risk of cancer. So,
and I was put on replacement, but it still was kind of decreased a level. I was knocked down a level of capacity, and I just had to realize you have to get, what served me before in sleep no longer served me. So I had to rewrite my own rules for self-care and say, you must get this much sleep and no longer, if I have control over it, allow myself to go under that level.
Yes. Yeah. I mentioned that just because I see so many women who come to me and have had risk reduction surgery and were not put on hormones. So just for anyone listening, that is standard of care.
This is so important for us to hear as women physicians, because it doesn't matter our field. It sounds like there's going to be a presentation that will overlap with what we do that can still be a symptom of menopause. And I do get those referrals around the average of 50 of ADHD, early dementia, bipolar onset at 50 is very uncommon because of that rage and impulsivity. And thank goodness, I've learned to ask the question of, where are you hormonally? Have you had that checked? Or do you still have periods? And give them that reassurance. And so important for us as women in medicine to pay attention to the overlap and have the sensitivity. Do not ignore. But I love what you said, believe your patients. And I'm all about compassion and empathy as a psychiatrist and as a coach. And I do have the luxury of time in my visits. But that's something that we can all do, whether we're on the side as a physician or as a patient or a patient advocate, because we do get our friends and family come ask us. We're part of a big mastermind, and the average age is 45 to 60. We're all women. And the conversation of menopause is so common. So I love that you're doing this job and that you're so passionate about it. And that part of what you do is teach other women in medicine to be better physicians and better advocates. And again, thank you for acknowledging that this is a massive change and that no, we're not, and I don't like the word crazy, but I'll use it of, so many of us come up like that, like, what's going on? I'm broken. I'm going crazy. This is not normal. And to appreciate, like, this is part of life, just because, right? Like, no one told us, like you said, they sort of prepare us for puberty and they sort of prepare us for pregnancy. And yet this is like you just have to be quiet for that period and then you'll be fine, right? Like, it's like your life is ending. It's so sad the way that we hear it. And I think it's worth mentioning again what you mentioned of that during that menopause transition, that's when more women leave their jobs. The rate of divorce goes up and the rate of suicide and mental health symptoms go up. So that's, again, it touches my heart. So because I felt it when you said it's so important. And of course, there's not something horrible going on if you're having those mood changes, memory problems. It could be your hormones. And then what's great is hearing you say, and there is hope. And there are things that we can do. And to advocate for your own self if you're going through menopause or if as a physician. So I think this has been so helpful. I can talk to you all day long. Thank you. I do have like a unique question to ask you. What is one rule or belief that you've rewritten for yourself that has helped you create more meaning and balance in your life?
I think, well, it was around the time that I started going through perimenopause, or I was years into it by the time I was feeling really bad. And I was ready to quit medicine. After all that training and all those years of experience, I thought, I cannot do this anymore. I was just so exhausted, and I couldn't see how I could stay in that job for X amount more years. And then, of course, found out all about what perimenopause and menopause is and started to learning about that. So I think for me, I would say I never dreamed I could pivot within family medicine. In my head, once, a primary care doc, always a primary care doc, and that was just what you did every day. I couldn't have believed I could be teaching, speaking to wonderful people like yourselves and making new connections on podcasts, and also a career pivot within work itself and seeing mainly women now who I would have found mainly throughout my career to be the hardest people to help at this age, because I didn't have the information. I didn't know how to help. And now it just seems so easy to me, and it is very nuanced. I don't mean it like that, but I just mean I really understand what's going on and I know I can help. And so I think that's been the biggest revelation for me.
I love that. And even as a pediatrician, I think your message is so important to raise awareness. If I was practicing general pediatrics right now, I think, how are my parents? So those parents coming in with teenagers, how can my awareness of this problem interact with me as the physician interacting with those parents and those changes? And how can I be even better as a pediatrician knowing about menopause and perimenopause, not just for my own self, but for my patients' parents or surgeons? Or I can just see how widespread this information and raising awareness can benefit physicians in all fields. And I'm just so grateful that you rewrote your course to become that expert and spreading that information. I look at that ripple effect outwards and how many people that you are impacting. And I see flipping that switch from, man, this is a really challenging patient, to, oh my gosh, I might have an answer.
Yeah, it's been a joy.
Yeah. And if people want to find you or learn more about what you teach, where are the places that our listener can find you, Dr. O'Sullivan?
I do a lot on Instagram. So my Instagram handle is Portland Menopause Doc. I have a website, and there's a wonderful woman called Erica who's helping me work on that. So I'm going to have a brand new website in March. I'm so excited about it. Because she's going to divide it up into education and what I do as a doctor, and then a separate part with, speaking opportunities as well. So that's all coming in the pipeline. And I am part of an amazing group here in Portland, Oregon, called the Portland Menopause Collective. And there are 4 of us physicians who are really dead set on educating clinicians and the general public on menopause. And we have I hope it's okay to mention, we have a conference coming up, Portland's first menopause conference, on March 15th at the Sheraton Airport Hotel. And so we're really working hard for that and so excited about it.
This is so great. Again, thank you so much for joining us. And I hope you listening got as much as we did. I have 2 pages of notes. And if you want to keep on listening to this information, please rate and review our podcast. Give us ideas. We're going to keep on bringing guests. Please share with your friends and stay tuned. Our next episode is coming up.
Do you want exclusive resources and the opportunity to connect with us? Then visit createmeaninginmedicine.com now, where you'll dive deeper into how you can create meaning in medicine. And if you're serious about optimizing your results, take 2 quick steps now. Connect with us on the website and tune in to the next episode.